This deep dive is customized for you, focusing entirely on high-yield dermatology. And when you look at the sheer volume of inflammatory, infectious, and malignant conditions that all manifest on the skin, it's a dizzying landscape. But it's an absolutely crucial one because the skin is so often the first visible sign of systemic trouble.
It is a truly comprehensive resource, and I think our mission today is really to cut through that overwhelming volume. We need to focus on the highest yield nuggets.
Exactly.
And not just, memorizing a list of symptoms, but really understanding the underlying mechanisms, the why.
The why and the so what.
And the so what, exactly. The clinical implications. We'll be moving systematically, starting with the very foundation, the immune response, then into invaders, and finally, malignancy.
Excellent. Let's jump right into the deep end then. We have to start with the most fundamental and honestly one of the most complex areas, how the body's immune system chooses to express its distress on the skin.
Right.
We're talking about the 4 distinct classes of hypersensitivity reactions.
The basics.
Okay, let's unpack this dense organizational chart that sort of governs these immune responses. The skin is often the first organ where we observe these 4 distinct types. Type I is famously fast, the anaphylactic response. But for those of us who need to grasp the foundational science, what is actually the mechanical trigger that makes it so instantaneous?
So type I is our anaphylactic and atopic reaction, and yes, it is defined by its speed. The mechanism hinges on the fact that the reaction components are preformed and ready to launch.
Okay.
An antigen comes along and acts like a bridge, cross-linking immunoglobulin E, that's IgE antibodies, that are already sitting bound on the surface of mast cells and basophils.
So they're already there just waiting.
They're already there. This cross-linking signals the immediate degranulation of those cells.
And when they degranulate, they're dumping a massive payload of chemicals, right?
Exactly. The rapid release of powerful vasoactive amines, primarily histamine, is the mechanism.
Histamine.
Histamine causes immediate vasodilation, increased vascular permeability, and local smooth muscle contraction. This is why you get that instant swelling, the bronchospasm in anaphylaxis, or the local edema in a typical skin reaction.
So the minutes-long response time is entirely due to the fact that the IgE antibodies are already armed and waiting on the cell surface.
That's it.
We see this in severe systemic reactions, like a bee sting or a food allergy, or localized reactions like urticaria, the wheal and flare.
Absolutely. And it's crucial to keep in mind that type I, type 2, and type 3 are all antibody-mediated reactions,
Right.
but they employ those antibodies in fundamentally different ways.
Which brings us directly to type 2, the cytotoxic reaction. It also uses antibodies, but the target has fundamentally changed.
Yeah. Type 2 shifts gears entirely. So instead of IgE triggering degranulation, here we have IgM and IgG antibodies binding to an antigen that is physically part of the cell's surface.
So it's attached to the cell.
It's attached. Think of the antigen as a target sign permanently affixed to a cell, like a red blood cell or a basement membrane cell. The antibody binds to that target. Once bound, it initiates the cell's destruction, which is why we call it cytotoxic.
How does that destruction actually happen? What's the mechanism?
There are 2 main pathways. First, the antibody-antigen complex fixes complement, which rapidly generates the membrane attack complex, or MSC.
The MSC complex.
Which punches holes directly into the target cell membrane and causes lysis, just blows it up.
Wow.
Second, the antibody acts as a flag, opsonizing the cell and tagging it for destruction by phagocytosis through macrophages.
That distinction is key. The antigen is physically part of the cell membrane, which drives the specificity of the attack. What are some of the classic examples that illustrate this?
We see this mechanism in several very serious autoimmune conditions. Autoimmune hemolytic anemia, where red blood cells are targeted.
Okay.
Erythroblastosis fetalis, where fetal red cells are targeted. Goodpasture syndrome, where antibodies attack the basement membranes of the lungs and kidneys. And even rheumatic fever.
So in each case, a specific cell or tissue line is directly destroyed.
Directly destroyed.
Now, type 3, the immune complex reaction, often confuses people because it sounds, kind of similar to type 2. But the location of the problem, the anatomy of the attack, is fundamentally different.
That's the critical contrast. In type 3, we are not targeting a cell. Instead, it involves the formation of circulating immune complexes.
Circulating.
Exactly. Visualize 3 items stuck together. The antigen, the antibody, typically IgG or IgM and complement. These complexes are soluble, meaning they float around in the bloodstream.
And because they're floating, they can end up anywhere.
Exactly. Because they are sticky and often intermediate in size, they tend to get trapped and deposit in small vessels or along basement membranes like those in the glomeruli or synovial tissue.
So the problem isn't the complex itself, but the fact it gets stuck, and then it initiates a destructive cascade.
Precisely. Once they deposit, they fix complement locally and act as massive chemical distress signals, attracting an army of inflammatory cells, specifically polymorphonuclear neutrophils, or PMNs.
Okay.
These PMNs attempt to clean up the complex, but in the process, they release large amounts of lysosomal enzymes. This causes widespread local inflammation and just collateral damage to the surrounding healthy tissue.
So type 3 is about collateral damage caused by where these complexes land,
Right.
resulting in a systemic inflammatory picture rather than that direct cell targeting we saw in type 2.
Exactly.
And this explains why we see conditions related to vessel and kidney damage.
It does. Because they deposit in blood vessels and glomeruli, type 3 reactions classically cause vasculitis and glomerulonephritis. Classic systemic examples are polyarteritis nodosa, immune complex glomerulonephritis, and the big systemic autoimmune conditions like SLE and rheumatoid arthritis.
Okay. Finally, we reach type 4, which completely breaks the antibody mold. It's the fourth and final type, the delayed hypersensitivity.
Type 4 is our cell-mediated reaction. It is delayed, often taking 24 to 72 hours to fully manifest.
So it's much slower.
Much slower. And instead of antibodies, this response relies entirely on specific sensitized T lymphocytes. When these T cells re-encounter the antigen, they don't produce antibodies. Instead, they release lymphokines.
And what do these lymphokines do?
The lymphokines recruit and strongly activate macrophages, leading to the localized chronic inflammatory response we see clinically.
So no antibodies at all.
None. Because there are no circulating antibodies involved, it's a pure cell-to-cell interaction, the reaction cannot be transferred via serum, which is an important diagnostic differentiator.
And this delayed manifestation is the key reason why, say, contact dermatitis from poison ivy or the readout of a TB skin test isn't instantaneous.
Exactly.
The T cells need time to migrate and activate the macrophage response. So really, understanding the speed and the mediator-performed IgE, IgAGM on cells, circulating complexes, or T-cell activation, that's the highest yield synthesis of this whole topic.
Absolutely.
So moving from those general mechanisms to specific skin pathologies, let's turn our attention to the most common inflammatory conditions, which often fall under the umbrella term of eczema or dermatitis. Let's start with atopic dermatitis.
Atopic dermatitis is a chronic inflammatory disease, typically beginning very early in life and often persisting. The fundamental pathophysiology is centered on a defective skin barrier.
A defective barrier.
Genetically, we know that there is often a mutation or deficiency in the protein filigrin.
And filigrin's job is essentially to hold the outer layers of the epidermis together, right? Like a glue.
It acts as structural scaffolding, so a filigrin deficiency means the epidermal barrier is compromised. It's leaky. This defect allows environmental allergens, irritants, and infectious agents to penetrate the skin much more easily, triggering the underlying inflammatory response. This causes intense pruritus or itching,
Which leads to scratching?
which leads to scratching, which further damages the barrier and in time results in the skin thickening we call enification. It's a vicious cycle of itch, scratch, and inflammation.
So the inflammation isn't just a simple allergic reaction, it's a structural failure that facilitates the allergy. And when you're taking a history, this structural failure is often predictable based on family background.
Absolutely. Clinically, we always look for the classic atopic triad, the presence of asthma, eczema, and allergic rhinitis, either in the patient or their immediate family.
Let's try ahead.
If you see that triad, you know you are dealing with a strong underlying atopic predisposition.
Beyond the genetics, what are the common environmental and external triggers that might precipitate a flare-up?
The list is pretty extensive. Rapid changes in temperature or climate, specific food allergens, especially in infants' household irritants like harsh soaps or detergents, and even emotional stress. And the compromised barrier also carries a significant clinical risk. These patients are highly susceptible to secondary infections, particularly colonization by Staphylococcus aureus or viral infections like molluscum contagiosum.
Right, because the barrier is broken.
It's broken, so these things can spread aggressively across the already damaged skin.
And the manifestation of atopic dermatitis isn't static.
Okay?
It changes dramatically with the patient's age, which is crucial for diagnosis.
Correct. In infants, we typically see acute weeping, pruritic, red papules and vesicles centered on the cheeks, face, scalp, and the extensor surfaces of the limbs.
Oh, the outside of the arms and legs.
Exactly. The diaper area is classically spared. As the child ages, the acute weeping subsides, the lesions become drier and scaly, and the distribution shifts to the classic flexural areas like the inner elbows and behind the knees.
And in adults, what's
But
the picture then?
in adults, the picture is dominated by the long-term consequences of scratching so, severe lichenification or thick, dry, fissured skin. Involvement is often concentrated on the hands, the neck, and again, persistent involvement in those flexural areas.
Speaking of other types, the sources provide a really useful algorithm for a dermatitis workup. Let's briefly synthesize the key differences between atopic eczema and the others listed.
Okay, so if we look at stasis dermatitis, the location tells the whole story. This is chronic inflammation occurring exclusively on the lower legs.
Just the lower legs.
It's directly caused by chronic venous incompetence and hypertension. It's fundamentally a problem of circulation and fluid dynamics, not a primary barrier defect. You'll find red, scaly, thin plaques, often with overlying petechiae or purpura from broken capillaries.
And contact dermatitis requires more of a detective's approach, right? It relies heavily on history.
That's right. Contact dermatitis, which we already classified as a type 5 delayed reaction, needs characteristic exam findings, often linear or sharply defined lesions, and a clear recent history of exposure to an irritant or an allergen.
Like nickel or poison ivy.
Exactly. No exposure, no contact dermatitis. It's that simple.
Finally, seborrheic dermatitis, which seems to be tied to yeast.
Seborrheic dermatitis is linked to the overgrowth of the yeast Melissetia. It's extremely common. In infants, it's cradle cap or a stubborn diaper rash.
Right.
And in adults, it affects areas rich in sebaceous glands, the scalp, eyebrows, nasolabial folds, and the midchest. The lesions are distinct, red, thin, and characteristically greasy or yellowish, scaly plaques.
Before we move on from the atopic diseases, we have to underscore a crucial key fact regarding the long-term management of severe inflammatory disease.
This is a critical safety synthesis. When we treat severe chronic inflammatory conditions like refractory atopic dermatitis or severe psoriasis with powerful long-term immunomodulating medications, specifically the TNF-alpha inhibitors.
The biologics.
The biologics, yes. We are dampening the immune system globally. And while this controls the inflammation, the source explicitly warns that long-term use carries an increased risk for lymphoma.
That isn't just a list of drug side effects. It reminds us that one of the immune system's vital functions is tumor surveillance.
Constant surveillance.
Constantly scanning and killing nascent cancer cells. If we damp down that surveillance system, we inherently increase the risk of malignancy. It's the trade-off.
It is the trade-off for controlling overwhelming inflammation.
Okay, let's pivot to psoriasis, another major chronic inflammatory disease driven by T-cell activation, but with a highly specific, easily recognizable presentation.
Psoriasis is a condition of accelerated keratinocyte turnover, and it has a classic clinical signature. You look for sharply demarcated, thick plaques covered by a characteristic silvery scale.
Silvery scale.
The most common locations are the extensor surfaces, the elbows and knees, and the scalp. And we must also screen for associated psoriatic arthritis, which can cause significant joint damage, leading to X-ray findings like pencil and cup deformity and nail changes like pitting and the oil drop sign.
What connects the histology to that clinical picture?
Diagnosis relies on clinical history combined with highly specific signs. The Auspitz sign pinpoint bleeding after the scale is gently scraped off reflects the superficial location of dilated capillaries.
Okay.
The Kogner phenomenon, which we also see in lichen planus, is when lesions appear specifically at sites of skin trauma. Histologically, we see massive epidermal thickening, elongated rate ridges, and the hallmark finding of sterile neutrophils accumulating in the stratum corneum. These are the Monroe microabscesses.
Those Monroe microabscesses, those pockets of inflammatory cells high up in the epidermis, that's what gives the silvery scale its unique, thick appearance.
It is. It's the physical manifestation of that runaway inflammatory process. Now, the treatment complexity here is vast.
It seems very stratified.
Highly stratified. For local disease, we start with high-potency topical steroids, calcipotriene, a synthetic vitamin D derivative, and topical retinoids like tazarotene.
And for moderate to severe disease.
Then we must escalate to systemic therapy.
And the systemic treatments are our heavy hitters.
Exactly. This includes methotrexate, acitretin, and then we have the powerful biologics. The TNF inhibitors, etanercept, infliximab, adalimumab, which block critical inflammatory signals. Newer agents target specific interleukins like ustekinumab and secukinumab.
And this brings us back to that crucial point about systemic risks. We mentioned the lymphoma risk with TNF inhibitors, but there are 3 mandatory blood tests before starting methotrexate or biologics. Why those 3 specifically?
That is non-negotiable patient safety. Methotrexate is hepatotoxic and myelosuppressive. Therefore, a complete blood count and liver function tests are mandatory.
Right.
For all biologics, especially the TNF inhibitors, mandatory screening for latent tuberculosis, either via PPD or IgRA, is required. Because these drugs suppress the cell-mediated immune response, they can reactivate latent infections.
Turning a contained infection into a life-threatening one.
Exactly. We also use UV light therapy, but providers have to monitor those patients closely for potential long-term skin cancer risk.
Okay, so contrasting the chronic T-cell-driven inflammation of psoriasis, let's quickly cover urticaria, or hives, which is the definition of an acute, rapid type I response.
Urticaria is rapid and volatile because it utilizes those preformed mast cell mediators. It's a type I hypersensitivity response resulting in the release of histamine and prostaglandins.
And clinically, it's the classic wheals and flares.
Sharply demarcated edematous plaques with surrounding erythema, the wheals and flares. Intensely pruritic. The key diagnostic distinction is timing.
Timing.
Individual lesions are transient. They last less than 24 hours. If they persist beyond 6 weeks, we classify the condition as chronic urticaria, which requires a much deeper workup.
Now we move into the conditions that demand immediate clinical recognition because they carry significant systemic risk, starting with erythema multiforme, or EM.
EM is described as a recurrent cutaneous reaction pattern. And the single most common infectious precursor you should always be looking for in the history is herpes simplex virus.
HSV.
HSV. It is the overwhelming antecedent cause, and the lesions are distinctive. Classic target lesions.
Right, the 3 zones.
3 distinct zones. A dusky center, which might be vesicular or crusted, surrounded by a pale edematous ring, and then a peripheral halo of erythema. They tend to favor the acral areas, palms, soles, and extensor surfaces.
How do we categorize EM severity, and how do we draw the line between EM and the truly terrifying spectrum of SJS-10?
EM minor is localized and generally uncomplicated. EM major involves mucous membranes and systemic symptoms like fever or headache. But the crucial takeaway is that EM is a distinct entity.
Meaning?
It absolutely does not progress to Stevens-Johnson syndrome or toxic epidermal necrolysis, and treatment is primarily supportive. Systemic corticosteroids are often not beneficial for EM.
That distinction, that EM is a separate entity, is vital. So let's discuss Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TOAN. These are genuine dermatologic and critical care emergencies.
They are life-threatening, drug-induced immune reactions. They represent a continuum of the same disease process. Massive keratinocyte apoptosis triggered by T cells.
It's all about the body surface area.
The distinction is purely based on the percentage of body surface area involved with epidermal separation. SJS is less than 10%. 10 is the most severe, involving greater than 30%. The overlap is between 10 and 30%.
And the mucosal involvement is key.
Critical. Over 90% of cases, eyes, mouth, genitals, it leads to terrible morbidity.
And the cause is almost universally pharmacological.
The mnemonic is often 7-B, sulfonamides, epilepsy meds like phenytoin and carbamazepine, and SAAs, allopurinol, penicillins. You look for diffuse erythema, purpuric macules, and the signature finding of epidermal separation.
The positive Nikolsky sign.
A positive Nikolsky sign, meaning light pressure or rubbing, causes the epidermis to shear off the underlying dermis and sheets.
The management here is comparable to a major burn victim, and we need to differentiate this from staphylococcal scalded skin syndrome, SSSS, which looks similar but has a totally different mechanism.
A very high-yield differential. SJS-10 involves full-thickness, eosinophilic epidermal necrosis seen on biopsy. The whole epidermis dies.
Okay.
SSS, conversely, is caused by a circulating Staphylococcus aureus exfoliative toxin. This toxin causes the split to occur much higher up in the epidermis, just under the stratum corneum.
And that subtle difference in the level of the split dictates the key clinical differences.
Precisely. Because SSSS is caused by a circulating toxin, it typically spares the mucous membranes. SJS-10 almost always involves the mucosa. Furthermore, SSSS is rare in adults, almost exclusively affecting children, whereas SJS-10 is common in adults and usually drug-caused.
And management for SJS-10.
Immediate, absolute discontinuation of the offending agent, followed by supportive care in a burn unit thermoregulation, fluid and electrolyte management, and meticulous wound dressings.
Okay, moving on to a distinct inflammatory condition, one that affects the fat layer itself. Erythema nodosum.
Erythema nodosum is a classic presentation of panniculitis, which is inflammation within the subcutaneous adipose tissue. It presents as highly characteristic tender erythematous nodules, appearing most commonly on the anterior shins.
And they heal like a bruise, right?
Exactly. As the lesions resolve, they don't ulcerate. Instead, they flatten and take on a bruise-like or contusion-like appearance. Systemic symptoms like fever and joint pain are common.
The most critical takeaway here is that erythema nodosum is almost always a manifestation of an underlying systemic disease.
Right, so you have to work it up.
We need the mnemonic to guide that workup.
The mnemonic "no causes" helps prioritize the investigation. NODES for TB, sarcoidosis, oral contraceptives, C-Rhone ulcerative colitis, acetaminophen and NSAIDs, uveitis, S-alpha drugs, and erythema multiforme or Yersinia.
So once you diagnose EN, the workup is mandatory.
Absolutely. Chest x-ray, PPD, IBD screening. The definitive treatment is identifying and aggressively treating the underlying disease.
Let's touch briefly on nummular eczema before discussing the destructive process of pyoderma gangrenosum.
Nummular eczema is chronic and characterized by relapsing, intensely pruritic, coin-shaped or nummular scaly plaques, usually on the extremities and trunk. It is strongly associated with xerosis or profound skin dryness. Treatment requires aggressive skin hydration and potent topical glucocorticoids.
Pyoderma gangrenosum, PG, on the other hand, is a serious destructive neutrophilic dermatosis.
This is an autoimmune condition driven by an overabundance of neutrophils, and it has powerful associations with systemic inflammatory diseases, primarily IBD, especially ulcerative colitis and rheumatoid arthritis.
And the presentation is very specific.
It presents as exquisitely painful, rapidly progressive ulcers with very specific clinical borders, a violaceous deep red border with classic undermined edges. The border looks rolled inward.
And what about pathology?
A key feature is pathology, the development of new ulcers at sites of minor trauma, which makes surgical repair dangerous unless the systemic disease is controlled. It's a diagnosis of exclusion, so you have to rule out infection and vasculitis.
And treatment is systemic.
Absolutely. High-dose systemic corticosteroids and other immunosuppressants like cyclosporine to halt the process. Local steroids just aren't enough.
The comparison between bullous pemphigoid and pemphigus vulgaris is arguably the most high-yield distinction in autoimmune dermatology. Everything flows from one fact: the location of the antibody attack.
This comparison is critical for diagnosis and for predicting mortality. So let's reinforce the mechanism for pemphigus vulgaris, or PV. The antibody target is against the desmosome,
The spot welds.
the spot welds, or the structural glue within the epidermis, specifically desmosoglines 1 and 3. Therefore, the separation is intraepidermal.
That structural failure inside the epidermis dictates the entire clinical picture.
It does. Because the blister roof is so thin, the blisters are flaccid and easily ruptured. You will see erosions far more often than intact blisters.
Which means the Nikolsky sign is positive.
It's positive. Skin shears off easily. And critically, because this desmosoglein 3 is heavily expressed in the mucosa, oral and mucosal involvement is extremely common, often the presenting symptom, and a major driver of potential mortality.
PV is often a disease of slightly younger adults, 40 to 60, and it carries a significant risk.
Yes, it is associated with drugs like ACE inhibitors, and because of the widespread painful erosions, the risk of fluid and electrolyte imbalance and infection means mortality is a real concern. Treatment is aggressive, high-dose systemic steroids plus immunosuppressives.
Now, let's use the contrasting mechanism to define bullous pemphigoid, or BP.
In bullous pemphigoid, the antibodies target the hemidesmosomes, the anchors.
The anchor's not the glue.
Exactly. The anchors securing the epidermis to the dermis at the basement membrane zone. The separation is therefore subepidermal.
If the entire epidermis is the roof of the blister, it explains why the lesions are clinically so much tougher.
Exactly. The blisters are tense, thick-walled bull that are difficult to rupture. Intact blisters are far more common than erosions. Because the roof is intact, the Nikolsky sign is negative.
Okay.
BP tends to affect older patients, usually over 60, and mucosal involvement is rare. Mortality is low.
And for diagnosis, how do we prove that subepidermal split?
The gold standard is a biopsy with direct immunofluorescence, or DIF, showing linear deposition of IgG and complement along the basement membrane zone. And ELISA for the specific BP antigens is the most accurate test.
So, to summarize the high-yield visual, PV is flaccid, fragile, oral lesions, positive Nikolsky, high mortality.
Yeah.
BP is tense, tough, no oral lesions, negative Nikolsky, low mortality.
And that crucial difference glue versus anchor dictates everything we need to know clinically.
Shifting focus now to infections, the human herpes viruses, or HHVs, are fundamental to understanding viral dermatology.
They are. These are DNA viruses that establish lifelong latency and are transmitted via direct physical contact.
Let's start with the most common, HHV1 and HHV2, the herpes simplex viruses. We know they cause painful vesicular eruptions, but where do they hide during latency and what triggers a recurrence?
They hide in specific nerve ganglia. HHV1, which is mostly oral lesions, remains latent in the trigeminal ganglia. HHV2, mostly genital, hides in the sacral ganglia.
And recurrence triggers.
Immune suppression, physical stress, illness, fever, or UV radiation. The recurrence is typically milder and shorter than the primary infection.
If we see a painful cluster of vesicles on an erythematous base, what is the fastest way to confirm it's HSV?
Well, a Zank smear showing those multinucleated giant cells is the classic high-yield finding. But in modern practice, a direct fluorescent antibody test, or DFA, is often preferred for rapid results.
And treatment.
Systemic antivirals, acyclovir, valacyclovir, or famciclovir, ideally begun within 72 hours. For severe infections or in the immunocompromised or with CNS involvement, IV acyclovir is mandatory.
Okay, next up, HHV3, the varicella zoster virus, or VZV. VZV causes chickenpox as the primary infection and shingles upon reactivation. It's an interesting difference in distribution.
Primary varicella is highly contagious and results in vesicles in various stages of healing. The classic dewdrop on a rose petal with a centrifugal distribution, so more lesions on the trunk.
And zoster.
Zoster reactivation presents as intensely painful vesicles confined to a specific dermatome, corresponding to where the virus lay latent in the nerve root ganglia. The pain often precedes the rash.
Zoster comes with severe, high-risk complications that demand prompt intervention.
They are critical. Postherpetic neuralgia, or PHN, is debilitating pain persisting for more than 30 days. Zoster ophthalmicus involves the ophthalmic division of the trigeminal nerve and requires an immediate ophthalmology consult due to the risk of vision loss.
You look at the Hutchinson sign.
The Hutchinson sign, vesicles on the tip of the nose, yes. And then there is Ramsay-Hunt syndrome, which involves facial paralysis.
How does early treatment affect the risk of PHN?
Treatment with high-dose oral antivirals within 72 hours of rash onset is critical because it significantly reduces the incidence and severity of PHN. And thankfully, we have highly effective vaccines for prevention now.
We have 4 other major HHVs to cover, each with unique clinical fingerprints.
HHV4, Epstein-Barr virus, or EBV, is the cause of infectious mononucleosis. Classic symptoms are exudative pharyngitis, lymphadenopathy, fever, and profound fatigue.
And the high-yield clinical pearl.
If a patient with EBV is misdiagnosed with strep and inappropriately given amoxicillin, they will almost certainly develop a widespread non-allergic maculopapular rash.
And HHV5, cytomegalovirus, or CMV.
CMV causes a mild mono-like illness in immunocompetent patients. The severe pathology occurs exclusively in the immunocompromised, where it causes retinitis, colitis, and pneumonitis. Treatment uses high-V ganciclovir.
HHV6 and HHV7.
These cause roseola infantum primarily in infants. It's characterized by a classic sequence: a high fever lasting 3 to 5 days, followed by the appearance of a rash after the fever breaks.
Finally, let's discuss 2 non-herpes viral infections, molluscum contagiosum and warts.
Molluscum is caused by a poxvirus, common in young children and highly prevalent in AIDS patients. The lesions are pathognomonic. Tiny, flesh-colored, dome-shaped papules with a distinctive central umbilication.
Central divot.
That central divot, yes, spread by direct contact. Treatment is destructive, curettage, cryotherapy, but often observation is sufficient as it is self-limited.
And verrucae, or warts, caused by HPV.
Right. Common warts are usually hyperkeratotic papules on the hands. The clinical concern is conyloma acuminatum, or genital warts, caused by low-risk HPV subtypes 6 and 11. These are soft, tan, cauliflower-like papules.
Moving to bacteria, let's start superficially with impetigo and escalate rapidly.
Impetigo is a highly contagious localized infection of the epidermis caused by group A strep and Staph aureus. It has the classic clinical hallmark of honey-colored crusting over red, slightly eroded skin.
And treatment.
For limited disease, topical antibiotics like mupirocin are sufficient. If extensive, systemic antibiotics like dicloxacillin are required.
At the other, much more critical end of the spectrum is necrotizing fasciitis. If this is suspected, time is literally tissue in life.
Necrotizing fasciitis is the most critical soft tissue infection we encounter. It is a deep, rapidly progressing infection along the fascial plane. It's often polymicrobial, and mortality approaches 50%.
The history is key here.
The history is characterized by pain that is severe, progressive, and critically out of proportion to the initial physical findings.
So if a patient is screaming in agony but the skin only looks slightly red, that is a huge red flag.
Absolutely. Systemic toxicity is rapid. Late, ominous signs include erythema spreading at a terrifying speed, crepitus on palpation gas produced by organisms like Clostridium perfringens, and the formation of hemorrhagic bullae.
Management is an aggressive, coordinated effort.
This is a surgical emergency. Immediate and expensive surgical debridement is life-saving and non-negotiable. Broad-spectrum antibiotics are mandatory, including penicillin G plus clindamycin. Clindamycin is crucial because it suppresses toxin production.
Let's pull back slightly to cover folliculitis, acne, and pilonidal cysts.
Folliculitis is the inflammation or infection of the hair follicles, usually staph. A specific type is eosinophilic folliculitis, seen frequently in AIDS patients. The one important exception is hot tub folliculitis, caused by Pseudomonas, which is usually self-limited.
Acne vulgaris is common, but has 4 distinct pathophysiological components.
Acne involves increased sebum, follicular hyperkeratinization, colonization by C. acnes, and resulting inflammation. We classify it by stage: comedones, inflammatory papules and pustules, and severe nodular cystic acne.
And the progression of treatment must match the severity.
Mild acne responds to topicals. Moderate to severe acne often requires oral antibiotics like doxycycline. The big gun is isotretinoin, reserved for severe nodular acne.
But it's a powerful teratogen.
A powerful teratogen requiring strict adherence to monitoring protocols, including monthly serial pregnancy tests for women of childbearing potential.
And pilonidal cysts.
These are abscesses in the sacrococcygeal region, thought to be a foreign body reaction to trapped hair. Treatment is incision and drainage.
Finally, we must mention leprosy, or Hansen's disease.
Caused by the acid-fast bacterium Mycobacterium leprae. It's still endemic in parts of the southwestern U.S. It affects the skin and peripheral nerves. The clinical presentation is a spectrum.
Tuberculoid versus lepromatous.
Tuberculoid leprosy shows strong cellular immunity, so you get few localized hypoaesthetic plaques. Lepromatous leprosy shows weak immunity, resulting in multiple symmetric nodules and widespread nerve damage. Treatment is a multi-drug regimen with dapsone and rifampin.
Okay, let's move to fungi, starting with Tinea versicolor, which is not a true dermatophyte but part of the normal flora.
Tinea versicolor is caused by Malassezia species, which overgrows in hot, humid conditions. It causes patches of varying color, hypopigmented or hyperpigmented pink patches, often on the chest and back.
How do we confirm that diagnosis quickly in the office?
The best initial test is a KOH prep of the skin scraping, which reveals the classic spaghetti and meatballs pattern of hyphae and spores.
Spaghetti and meatballs.
Treatment is highly effective with topical antifungals like ketoconazole shampoo.
Candidiasis is our classic opportunistic yeast infection.
Candida albicans overgrowth is common in patients with impaired immunity, like those with diabetes. Intertriginous infections are characterized by beefy red erythema with the crucial hallmark of satellite lesions.
Those small pustules scattered around the main plaque.
Exactly. Treatment is topical azoles or systemic fluconazole for more severe cases.
Now for the dermatophytes, the true fungi that eat keratin.
These fungi, trichophyton, microsporum, infect keratinized tissue, skin, hair, and nails. We classify them by location. Tinea corporis is ringworm. Tinea pedis is athlete's foot. Tinea capitis is on the scalp and can form a boggy mass called a carrion. Tinea unguium is on onychomycosis of the nails.
Diagnosis again relies on microscopy, but treating hair and nail involvement changes the game completely.
The best initial test is the KOH skin scraping, showing the hyphae. But the crucial treatment synthesis is this. Skin infections can often be treated topically. However, any involvement of the hair or extensive nail infection requires systemic oral antifungals, like griseofulvin or terpenafine.
Because topicals just can't penetrate.
They can't penetrate the keratinized shaft or nail plate effectively.
Finally, the parasites, lice and scabies.
Lice, or pediculosis, live off blood on the scalp, body, or pubic area. The diagnostic key is identifying the nits, or eggs, which are firmly cemented to the hair shaft. Treatment uses topical permethrin and environmental cleanup.
Scabies is usually diagnosed by history, the intensity and timing of the pruritus.
Scabies causes intense, agonizing pruritus, classically worse at night as the mite burrows. Common sites are the hands, wrists, and axillae. A severe diffuse form called crusted scabies is seen almost exclusively in immunocompromised patients.
And treating.
5% permute cream applied neck down to the toes, requiring at least 2 applications. Oral ivermectin is crucial for treating crusted scabies.
We shift now to conditions caused not by invaders or immune defects, but by circulation and pressure issues. Fundamentally, problems of tissue perfusion.
Right.
Decubitus ulcers, or pressure ulcers, are an ischemic event from continuous pressure. The staging system is the high-yield framework for assessment.
The staging is non-negotiable. Stage 1 is intact skin with non-blanchable erythema. Stage 2 is partial thickness loss, a shallow ulcer or blister. Stage 3 is full thickness loss down to the subcutaneous fat. Stage 4 is the most severe, exposing muscle, bone, or tendon.
And the distinction of an unstageable ulcer.
An ulcer is unstageable if the tissue loss is covered by slough or eschar, obscuring the true depth. If you can't see the bottom, you cannot stage it. Prevention repositioning every 2 hours remains the gold standard of care.
Next, gangrene, which signifies irreversible tissue death.
We categorize 3 types. Dry gangrene is due to insufficient blood flow from atherosclerosis. The tissue is ischemic, cold, dry, and appears black or shriveled.
Mummified.
Mummified, yes. Wet gangrene involves bacterial infection superimposed on ischemia. The tissue is swollen, bruised, blistered, dark, and highly malodorous.
And the most urgent form, gas gangrene.
Gas gangrene is caused by the anaerobic Clostridium perfringens. It is defined by rapid tissue destruction and the production of gas, which is detectable clinically as crepitus. Treatment for all gangrene is immediate surgical debridement or amputation, combined with broad-spectrum antibiotics. For gas gangrene, hyperbaric oxygen is a crucial adjunct therapy.
Let's cover a cluster of specific inflammatory disorders, starting with lichen planus.
Lichen planus is a self-limited chronic inflammatory disease affecting the skin, oral mucosa, and genitalia. You must remember the 6 P is mnemonic: pruritic, purple, polygonal, planar, papules, and plaques.
And the key signs.
Witherspoon lacy, reticulated white lines seen especially on oral lesions, and the Koebner phenomenon, which we previously saw in psoriasis.
And there is a critical systemic association here, which mandates screening.
Yes, lichen planus has a strong association with chronic hepatitis C virus infection, requiring appropriate viral screening.
Then there is rosacea, a chronic disorder of the pilosebaceous units.
Rosacea manifests in 4 subtypes. The most common are the erythematotelangic, ectatic, facial erythema and flushing, and the papulopustular, which resembles acne but lacks commonones.
And the triggers are behavioral and environmental.
Hot drinks, spicy foods, alcohol, sun exposure. Treatment focuses first on avoiding those triggers, then topical agents like metronidazole. Oral doxycycline is reserved for moderate to severe disease.
Pityriasis rosea is often benign, but it can mimic other serious rashes.
Pityriasis rosea is an acute dermatitis thought to be related to HHV7. It starts with a single larger salmon-colored plaque called the Harrod patch.
The Harrod patch.
1 to 2 weeks later, a secondary eruption of smaller papules appears, classically on the back in a distinctive Christmas tree pattern. It resolves spontaneously, but it is high yield to remember that the differential requires ruling out tinea corporis and secondary syphilis.
Now for the pigment disorders, vitiligo and acanthosis nigricans.
Vitiligo involves the autoimmune destruction of melanocytes, resulting in sharply demarcated, non-scaly white patches. It is an autoimmune condition and is often associated with other endocrinopathies like type I diabetes and hypothyroidism.
Acanthosis nigricans, a crucial sign of internal metabolic issues.
This presents as velvety dark brown epidermal thickening in intertriginous zones like the neck and axillae. Its most common association is with insulin resistance, seen in type 2 diabetes and PCOS.
And sometimes malignancy.
The sudden, extensive onset is a rare but critical perineoplastic sign of an underlying adenocarcinoma, often GI. Treatment focuses entirely on treating the underlying metabolic pathology.
Moving into skin growths, we must distinguish between the common and benign and the common and premalignant, starting with seborrheic keratosis, or SK.
They look like they were literally placed on the skin and could be scraped off the stuck-on appearance. They are exophytic, waxy, brown papules, overwhelmingly common in older people.
And they are benign.
Benign. But the one clinical pearl you must know is the Lezer-Trelov sign, the sudden explosive eruption of multiple SKs, which is associated with underlying internal malignancy, most often GI adenocarcinoma.
In stark contrast to the benign SK, Actinic keratosis, or AK, is the definitive premalignant lesion.
AKs are caused by cumulative UV exposure. They're characterized by flat areas of erythema and scale with a sandpaper-like texture. This is a high-risk lesion because AKs have a concrete 5–10% chance of transforming into invasive squamous cell carcinoma.
Therefore, the treatment is not optional, it's preventative destruction.
Exactly. Treatment aims to destroy the atypical keratinocytes before they become invasive. Standard treatments include localized cryotherapy or field treatments using topical 5-FU or imiquimod.
Let's start the three main malignancies with cutaneous squamous cell carcinoma, or SCC.
SCC is the second most common skin cancer. Risk factors include chronic UV exposure, but also chronic inflammation like old burn scars, marginal ulcer, and especially in immunocompromised patients.
What does a typical SCC look like clinically?
SCC often presents as a firm edematous papule or nodule that may ulcerate or bleed easily. Unlike BCC, SCC has a significant metastatic potential, particularly if it demonstrates perineural invasion, which can be suggested clinically if the lesion is painful.
And diagnosis.
A biopsy, showing full-thickness, atypical keratinocytes, and keratin pearls. Treatment is surgical excision or Mohs surgery for high-risk areas.
Basal cell carcinoma, DCC, is the most common skin cancer, yet the least dangerous in terms of metastasis.
BCC is slow-growing and locally destructive, but metastasis is exceedingly rare. The main risk factor is cumulative sun exposure. The nodular subtype is the classic presentation, a pearly white, translucent, dome-shaped nodule with overlying fine blood vessels called telangiectasias.
Finally, melanoma. This is the one we must catch early because prognosis hinges almost entirely on one measurement.
Melanoma is the most life-threatening skin cancer due to its high metastatic potential. Clinical detection relies heavily on the ABCDE's mnemonic: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolution.
We need to detail the primary subtypes and their growth patterns, as that defines how dangerous they are early on.
The superficial spreading type is the most common. It has a prolonged horizontal growth phase, which allows for early diagnosis. The nodular melanoma is highly aggressive because it skips the horizontal phase and rapidly enters the vertical growth phase.
Which means a worse prognosis.
A poor prognosis, yes. We also have ecrolentiginous melanoma on the palms, soles, and nail beds, and lentigo maligna, usually on sun-damaged skin of the face.
So the prognosis hinges almost entirely on the tumor depth.
Absolutely. The single most important prognostic factor is the Breslow thickness, the depth of invasion measured in millimeters. This, along with T&M staging and ulceration, determines treatment. Treatment is wide surgical excision. Sentinel lymph node biopsy is essential for accurate staging.
Okay, we can finish the neoplasm section with key benign and related vascular lesions, cherry angiomas.
Small, vascular red papules that appear anywhere. They are harmless and require no treatment unless desired for cosmetic reasons.
Infantile hemangiomas, or strawberry hemangiomas, have a predictable life cycle.
These are capillary hemangiomas seen in infants. They undergo a rapid growth phase, but then spontaneously involute or regress, typically by age 9. Persistent lesions may be treated with beta blockers.
And pyogenic granuloma looks concerning because it bleeds so profusely.
It's a lobulated capillary hemangioma that develops rapidly, often following minor trauma or during pregnancy. They ulcerate and bleed easily. Treatment is typically surgical excision with cauterization.
And necrobiosis lipoidica, which demands a systemic workup.
NL presents as red-brown to yellow annular plaques on the lower extremities, and it is overwhelmingly associated with diabetic patients, especially type 1 DM. Finding NL mandates immediate screening and management of diabetes.
Let's conclude with a couple of inherited and environmental skin changes. Ichthyosis vulgaris.
Ichthyosis vulgaris is characterized by diffuse, dry dermal scaling, often described as fish-like scales. It's caused by an inherited mutation in the filigrin gene, the same protein deficient in atopic dermatitis. Treatment is supportive, intensive use of emollients and moisturizers.
And the unavoidable effects of aging and, more specifically, chronic sun exposure.
Age-related changes include the natural degeneration of elastic fibers and thinning of the skin. Chronic UV exposure leads to photoaging, characterized by solar elastosis, a thickening and leathered appearance of the skin.
Which brings us to the final, crucial preventative takeaway: sun protection.
UV radiation is the primary driver of extrinsic aging, hyperpigmentation, and the destruction of collagen and elastin. Sun avoidance is the most effective strategy. When exposure is unavoidable, broad-spectrum sunblock with an SPF of at least 30 is necessary.
And it has to be reapplied.
Critically, it must be reapplied every 2 hours, especially after swimming or sweating, as protection diminishes rapidly.
We have completed an expansive and detailed deep dive into high-yield dermatology. We successfully navigated the landscape, starting with the delicate balance of the immune system.
Hypersensitivity, atopic derm, psoriasis.
We moved into the critical battleground of infections, distinguishing the latency of HHVs, the urgency of necrotizing fasciitis, and the unique patterns of fungal and parasitic invaders. And finally, we covered the crucial topic of skin neoplasms, where early recognition is everything.
What's fascinating here, and what should be your enduring takeaway, is how clearly the skin functions as a mirror for internal medicine. We saw repeatedly that the most serious diseases, from SJS10 to necrobiosis lipoidica signaling diabetes, are often the first visible manifestations of a systemic health issue happening inside the body.
It reinforces the crucial importance of a thorough history, looking beyond the lesion itself to the entire patient picture. We saw that some conditions, like pityriasis rosea, are self-limiting, while others, like psoriasis, require lifetime management and vigilance for complications.
Given how absolutely critical early diagnosis is for conditions like melanoma, where prognosis is defined by the Breslow thickness, the depth of invasion, consider this provocative thought. If the prognosis is entirely determined by how deep the tumor has grown, how might future advances in non-invasive, AI-assisted screening tools fundamentally change the staging process and prognosis factors we rely on today?
Catching them earlier.
Catching these dangerous lesions when they are still microscopically thin, long before they meet the current clinical criteria of the ABCDEs. It suggests that the future of dermatologic prognosis may be decided by technology, not by the naked eye. Something for you to mull over as you continue your deep dive into the field.